Welcome to our webinar on robotic cystectomies for bladder cancer. We are delighted to have you all here today. Let's dive into this important topic that affects many people and their families. Support for the webinar was provided by Intuitive. Fight Bladder Cancer retains all editorial control. When it comes to bladder cancer surgery, there are different approaches available, each with their own advantages and disadvantages. Both robotic and traditional surgery have their merits. Traditional surgery, often referred to as open surgery, has been a long-standing and proven method in the field. It involves a larger incision but provides direct access for the surgeon to perform the necessary procedures. On the other hand, robotic surgery, a more recent technological advancement, offers the benefits of smaller incisions, enhanced precision, and improved visualization through the use of robotic-assisted tools. Your surgeon will assess various factors, including your medical history, the stage of your bladder cancer, and your overall health to help guide the decision-making process. They will take into account the potential benefits and risks associated with both approaches, as well as your individual circumstances to recommend the most suitable option for you. It's crucial to have an open and honest conversation with your healthcare team. Ask questions, express any concerns or preferences you might have, and actively participate in the decision-making process. They are there to support you and provide the guidance necessary for you to make informed choices about your treatment. Fight Bladder Cancer is a charity that supports people around the UK affected by bladder cancer. Our vision is a future where everyone survives bladder cancer and lives long and well. Our mission is to lead the fight against bladder cancer, driven by patient and family insights. We are patient-led and we are ambitious. I am thrilled to introduce our esteemed speakers for today's webinar. Firstly, Matthew Perry, Consultant Urological Surgeon at the Royal Surrey NHS Trust. With extensive experience and expertise in the field, Mr. Perry has been at the forefront of advancing surgical techniques for bladder cancer treatment. Joining us alongside Mr. Perry is Alison Roodhouse, Cystectomy/Bladder Cancer Nurse Specialist at the Royal Surrey County Hospital. With her extensive knowledge and experience, Alison will provide vital information about what to expect before, during, and after the operation. She will address important topics such as surgical preparation, post-operative care, and follow-up measures to ensure a smooth recovery process. Bladder cancer patients who have undergone robotic cystectomies, Anne Was and Mark Chrissy, will also share their personal experiences, offering invaluable perspectives and practical tips on how to prepare for the procedure. Following the presentations, we'll have a live question and answer session where you will have the opportunity to ask questions and seek clarification on any aspect of robotic cystectomies or any other related concerns you may have. So please, if you've got any questions at all, pop them in the question and answer box that you can see on your screen. At the end of this webinar, our goal is for you to feel empowered, well-informed, and confident in collaborating with your healthcare team to make the best decisions for your bladder cancer journey. If you have any questions at all about anything that you've heard today, you can contact us on info@fightbladdercancer.co.uk. Mr. Matthew Perry is a pelvic cancer specialist providing surgical services for complex pelvic cancer. He specialises in robotic surgery for the treatment of prostate and bladder cancer. He is Clinical Director for Urology Services at the Royal Surrey, an advisor to Cancer Research UK, and a trustee of the Prostate Project charity. The next 10 minutes of this webinar contain images of surgery and tumour-filled bladders. You may wish to minimise your screen for the next 10 minutes if you do not wish to see these images. Matthew, the floor is yours.
Good evening all. As said, I'm Matthew Perry. I'm a consultant urological surgeon over at the Royal Surrey in Guildford, UK. And I've been doing robotics since 2007 when they first came on the scene at the St George's Hospital in South London. I introduced robotic cystectomy at that hospital in 2010 and then helped my colleague Krishna Patil introduce robotic cystectomy here at the Royal Surrey Hospital in 2013. So robotic cystectomy has been around for quite a while now, but it's only really coming to the fore since more recent information and data has come out about it. So what on earth is robotic surgery? Well, robotic surgery really is computer enhanced operating, and it's essentially like buying a new car these days. When we sit in our new cars, there's lots of computerization around us to help us park, to help us monitor where the speed cameras are, to help us keep within the lanes of the motorway, and so on. So we are familiar with these computerized enhancements in our daily lives, and actually surgery is no different. What robotic surgery is not is is me designing a program, pressing a button, and walking out of the room whilst the machine gets on and does your operation. That is not what it is at all. It is one of my oncology colleagues called it a puppet on a string. So we drive this machine, and it's using the skill of the surgeon to drive a surgical machine to enhance outcomes. And I've got a little video here of what a robotic theatre looks like. So this is a robotic theatre. So the machine is engaged with the patient, and we are watching on these screens, and you can see the instruments being used there on the screen. Instrument tray, bedside surgeon. Surgical console. So the surgeon is driving the machine, and bear with me, using those hand controls to drive the instruments. And we look down these 3D imaging visors to see exactly what we're doing. Instrument on the right is 5mm, instrument on the left is about 8mm in size. We have all of the imaging displayed at the same time. And in general, keyhole surgery just means that you can get up and get moving quicker. And so what does that mean? Well, that means that these two men who had their operations the day before, one's got a neo bladder, one's got an ideal conduit, and they're out of bed at 7:30 the following morning, and one of them is even smiling. So what on earth is a radical cystectomy? Well, in the man, it's a removal of the bladder and a prostate, so we call it a cystoprostatectomy. And traditionally, in the woman, it's a cystectomy, removal of the bladder, but also a removal of the womb, a hysterectomy, and often a removal of the ovaries, an oophorectomy, although we're trying to be less aggressive with the female sexual organs of the womb and the ovaries, and there's some evidence that if you don't need to move these organs, then one shouldn't. Who should have a robotic operation? Well, we don't do open surgery anymore, and so over the last 10 years here at the Royal Surrey, we've done nearly 700 robotic cystectomies, and of those we've only done 2 open cases, and those are generally in people who've had multiple other surgeries and their abdomen is completely scarred because of previous surgeries. So we say that if you're fit for an operation, there's no limit on who should get a robotic assisted radical cystectomy. And I know that can vary to other centres. They have various limits on various things such as a body mass index or an age. But with us, we feel that with our experience, nobody is excluded if they are fit for an operation, and not everybody is fit for that. It now currently takes us about 5 hours. We have a standard blood loss of about 200 mils, and the average length of stay in our hospital is 5.2 days. We put people in intensive care for 2 nights, and that's just part of our local protocol, and every hospital will have their own different protocols. But even though people are in hospital for such a short period of time these days, and in my days when I first started, people were in hospital for 2 or 3 weeks, but now with robotics and keyhole surgery, that's down to such a short period of time. But it has a large impact, and we say no driving for about 6 weeks and no lifting for about 12 weeks. And this is because of the risk of hernias and in some women prolapses. And so to try and stop that, we say no lifting for 12 weeks until all of the core muscles and the pelvic floor muscles have all improved their strength. So what about the long-term and short-term outcomes? Well, this was our first 3 or 4 years worth of patients here at the Royal Surrey, and essentially over 150 people. The average length of stay was 5 days, but the most common length of stay after an operation is 4 days. And so the majority of people are getting out of hospital quickly. Is it a dangerous operation? Yes, it is. It is associated with a 3 or 4% risk of death from the operation, with what's called a 90-day mortality rate. And so that is people dying within 90 days of their operation. Complication rates are high, and thankfully most of these are minor complications, but about half the people who have this operation will experience some form of complication, be it their bowels don't work properly for a few days, or they'll get a cough and a cold, or they'll get a wound infection or a urine infection. So how do we get over some of these issues? Well, we have an enhanced recovery protocol, and I'm sure my colleague Alison Roodhouse will be talking a bit more about these. But these protocols help focus all of the other staff around the patient so that we're all doing the same thing with the same aims, getting people out of hospital in a safe and secure manner. And when in doing these enhanced recovery protocols, we find that you save time on length of stay, on antibiotic usage, on drugs for pain relief. Everything is better as everybody is singing from the same hymn sheet, as it were. The main challenges of getting over your radical cystectomy are getting your bowels to work in a happy and consistent manner. All we do for an ileal conduit part of the reconstruction after a bladder removal is take out about 15 centimeters or 6 inches of the gut. But that has an impact, and the gut can really slow down. And for some people, that means constipation. For some people, that means diarrhea. And for some people, they flit between the two. And so getting patients mobilizing and getting them back onto a diet as quickly as possible is the best way we've found to get over this. The UK has been quite forward-thinking in trying to work out what is the best way to have your radical cystectomy. Is it these new fangled machines, or should we continue to do open surgery? And so the IROC study was carried out at about 9 centres in the UK with just over 380 patients having a radical cystectomy. This showed this was basically looking at quite a basic outcome, and the outcome was those patients alive and out of hospital at 90 days after their operation, and whether there'd be a difference between the two groups. And really the headlines results of this is that out of hospital and alive after a robotic assisted radical cystectomy in these groups of patients were 1.2% versus 2.6% if you were to have an open radical cystectomy. Now, these differences are small, and so actually within this group of patients, they actually had quite a lower than expected risk of death, thankfully. There were some really strange findings in this study that showed that if you were to have a deep vein thrombosis, or a DVT, or a thromboembolic event is what they're sometimes called, it was far less likely to be due to in those patients who'd had a robotic assisted operation as opposed to an open operation. Wound complications were far less in the robotic, and that stands to reason, really. The wounds are much smaller. And quality of life was much better early with robotic surgery than it was with open. But at 12 weeks, 3 months, those quality of life changes were the same. They were equivalent. So in summary, I would say that this is all about the team, really. The robotic assisted operation is not about you and your surgeon. It's actually about you and your surgeon's team and what experience they've had. And because of studies like IROC, most big cystectomy centres are changing to robotic radical cystectomy. But in your local area, it may be that your service and your team are better open surgeons than they are robotic surgeons. So just because they don't do robotics doesn't mean to say they aren't going to give you an excellent outcome. And so I would still trust in your local team. And the other thing to say is that robots, they're here to stay, and they're going to be not only in our cars, but in our operating theatres as well as in our homes. And thank you very much for giving me the opportunity here today.
Thank you, Mr. Matthew Perry. Alison Roodhouse treats patients with non-muscle invasive and muscle invasive bladder cancer. She is currently the Cystectomy Bladder Cancer Clinical Nurse Specialist at the Royal Surrey County Hospital in Guildford. Alison, the floor is yours.
I'm going to take you through what you should need to know about having a robotic cystectomy. It's important that you're as active as possible and try to improve your fitness as much as you can. Even if it's a short period of time between your operation date and the decision to have the operation, there's still a little bit of a fitness you can improve, which will help during the operation and your recovery. Eat a nice healthy diet with plenty of fruit and vegetables and also plenty of lean proteins, and try to keep your kidneys nicely flushed with non-alcoholic fluids. We're very lucky at the Royal Surrey to have a prehabilitation service. Prehabilitation is a mix of physiotherapists, occupational therapists and dietitian, and there's lots of health and wellbeing sessions that go along with these. They offer an exercise program for each individual patient with either online classes, face-to-face or at-home classes. If you're not able to access a prehabilitation service, there's lots of exercise classes you can do on YouTube for free that will help improve your fitness. For those patients having a stoma, it's important to do core exercises, and those having a neobladder, they teach them how to do pelvic floor exercises to strengthen those muscles before the operation, which will put them in good stead afterwards. There's also a session they offer from the anaesthetist that looks at the operation and what to expect in intensive care afterwards. Enhanced recovery is something that most hospitals offer, and it's a way to get you through the operation and home and recovered quicker. And lots of things incorporate this. Getting fit before your operation, having practices with stoma bags, etc. will help with before the operation. What type of urinary diversion is best for you? This will be something you've discussed with your urologist, and some people it may not be a choice. They may have to have a urinary diversion or stoma, whereas other patients may choose to have a neobladder. What to expect from your operation? It's a general anaesthetic, which most people I would think would imagine, but I have had a few patients ask if they could have a spinal and be able to watch the operation, which obviously is not possible. You tend to have a spinal analgesia before the anaesthetic, where they inject into the back, and that's usually a painkiller that lasts for about 24 hours, so it helps during the anaesthetic. But come the next morning, when the lovely physios are coming to get you out of bed and walking around, it's still nicely working in the system. It's a long and complex operation, taking somewhere between 5 and 7 hours, depending on whether you've had previous surgery, which can make it more difficult, but also if you're having a neobladder, then that can take longer to make than a stoma. For the operation, you're positioned in a head down position, somewhere between 30 and 45 degrees. As Mr. Perry will have talked about, the robot has 4 arms to it, and one is a camera which is put in first, and the abdomen is inflated with carbon dioxide gas. This is so we can see further, and by putting you in a head down position, it increases the access to the bladder. After the operation, because of this strange position and the abdomen being filled with gas, you might notice you have some neck and shoulder pain after the operation, which usually lasts for about 24 to 48 hours. Sometimes you can get some trapped gas right at the top of the shoulders, which can also be uncomfortable. One of the things I always point out to patients and also their relatives is that their face can be quite puffy and swollen, particularly around their eyes where fluid is trapped, and quite often that can be quite shocking to the visitors if they're not expecting it. Most of the operation is done through 6 little holes in the tummy, 4 for the robot, and you have an assistant with a further 2, and then we only need to make a small cut of about 10 centimetres horizontally across the base of your tummy to remove the specimens at the end of the operation. All of these wounds are closed with dissolvable stitches, so there's nothing to take out afterwards. We put a drain in to collect any fluid that may be inside, particularly the lymphatic fluid if the lymph glands have been removed, and this usually stays in for 24 to 48 hours. Your tummy is already a little bit like a pincushion with all the holes we've made, so we tend to put a catheter into the now redundant water pipe and drain the fluid that way. Obviously, if you have a neobladder, we've attached that to the urethra, and therefore we would need to put one in through your tummy. After your surgery, you usually go to either a high dependency unit or an intensive care for 24 to 48 hours for close monitoring. You will, however, be up and about and walking and eating and drinking. We usually start fluids on the evening of your operation, and if all's well the next morning, start you on a liquidy type of light diet, things like soups, jellies, porridge. You will be out of bed walking straight away on the morning after your operation, and the more walking you can do, the better. Having pelvic cancer surgery can put you at the risk of deep vein thrombosis, pulmonary embolus, and chest infections, and getting up and walking is one of the best things you can do to prevent these happening. We will also put you on a blood thinning injection called dalteparin that reduces the risks of clots further, and you will have this whilst in hospital and then every day for up to 4 weeks when you go home. It's a very small needle and an easy injection, and we'll teach you how to do this yourself. We've obviously done bowel surgery in addition to removing your bladder, because we've used that piece of bowel either to make your stoma or to make the neobladder. And the bowel has a natural action called peristalsis, which is constantly moving through in waves. And when the bowel has been handled, which obviously yours has, this natural action can slow down and sometimes stop. So we used to keep you nil by mouth after this operation, but what we've learnt is our bowels are really lazy, so we need to stimulate them to get them working, and that's why we start with the liquidy type light diet, so we're not over facing the bowel but giving them enough stimulation for it to start and work. Chewing gum is very good in helping the bowel to get working again, because when we chew, our gut thinks food is coming and then starts this peristalsis. So even when you're not eating very much, chewing gum can certainly help. Although this is not as painful as an old-fashioned open operation, one thing that can be particularly painful is trapped wind. And moving around and walking around will also help that. When you're sitting down, your bowel is crunched up, and when you tend to lay down, the bowel goes quiet. So it's a good thing to walk around as much as you can do with that. We try to avoid any of the strong painkillers if we can. We tend to use a lot of intravenous paracetamol, as that can be very effective. The reason we try, if we can, to avoid morphine and codeine and drugs like that, it is also that it slows the bowel down. So if you're getting a lot of pain from trapped wind, the last thing we need is to give you further treatment that's going to make that worse. You'll start with your stoma care if you have a stoma immediately after the operation, and we have a very good team at Guildford that do twice daily teaching to try and make sure that you have enough confidence and are competent before you go home, because we don't want that to slow your recovery. If you have a neobladder, you'll have a catheter in. Now, the neobladder is made from bowel tissue, and bowel tissue naturally produces mucus, and mucus can then block your catheter. And it's important when you have a neobladder that we keep that empty, because it won't heal if the sutures are under tension. So we will teach you how to flush your catheter several times a day to keep it patent, and if it does block with the mucus, we'll also teach you how to wash it out before you go home. One of the most frequent questions I'm asked even before patients come in for their operation is, when can I go home? Most of our operations are done on a Friday, with patients going home Tuesday, Wednesday or Thursday. There are 3 things that we need from patients before we'll allow them home. The first thing is that they can eat and drink okay, and if they've been fine over the weekend with the liquidy type light diet, we will start them back onto normal diet, usually on the Monday, which is day 3 after their operation. Small portions often are far better than trying to have 3 main meals. So I would normally expect people to have 5 or 6 small little meals a day to help them get their diet back, their appetite back. We obviously can't let patients go home if they can't keep fluids down. The second thing is that their bowels. Ideally, we like you to have your bowels open before you go home. But if you're passing lots of wind and your tummy is soft and not distended, we will let you go home, because we do appreciate quite often in your own environment, your own toilet, things happen a lot more naturally. And the third and probably the most important thing, if you have a stoma, that you're able to look after that and are confident when you go home. If you have a neobladder, it will be able to be washing your catheter out comfortably and know what to do if you have any problems. Sometimes the bowel doesn't get going as quickly as we'd like, and that can sometimes hold up the discharge, but most people go home around day 5. We get you medically fit to go home, meaning you won't need our intervention anymore, but you're going to be absolutely shattered, really tired. But it's important that when you go home that you still continue with your exercise, and we do expect you to do a walk in the morning and also in the afternoon. Now, that might only be to the end of the garden or the end of the drive to start off with, but it's important that you keep active. If you're tired after lunch, go down and have a proper sleep for an hour or 2 and then get back up. What we've found is those patients that have good quality exercise and good quality sleep do far better than those patients that try and stay awake all day and doze in the chair. You will be able to look after yourself, so you'll be able to wash, dress, make a drink, make a meal, but it's quite nice, if possible, to have somebody around just for a bit of moral support. We don't like you doing any heavy lifting for the first 2 to 3 months following surgery. Keyhole surgery is really good, but one of the downsides is that the little wounds heal very quickly on the outside, lulling you into a sense of security, when obviously all the tissues and muscles need to heal inside, so we still need to be careful. Try to avoid any lifting, more than anything about more than half a kettle of water, because anything more than that initially can increase the intra-abdominal pressure, which can cause hernias at the port sites where the instruments have gone through. It's also important from a long-term perspective for those patients with a stoma, because you are at risk of developing a hernia behind the stoma because of the going through the muscle into your abdominal wall. Your local stoma support nurse will be able to fit you up with a support belt for heavy lifting after this time. Going back to work, most people by the 3 months are ready to go back to work and are doing all of their own normal activities, although they may still be a little bit tired. I would usually suggest to patients working out with their managers to go back at 3 months. It's much easier to go back sooner if you're ready than trying to negotiate longer time if you put yourself under pressure. You can drive after 4 weeks when you feel able to do an emergency stop. From your stoma point of view, you will be referred to your local stoma team and they will give you ongoing support as and when you need it. The recovery from a neobladder is more complicated. You'll have a catheter in for about 3 weeks, allowing all the joins in your new bladder to form. And then if all's well, we will take the catheter out and then we will need to teach you bladder retraining. To start off with, your neobladder will be only hold between 50 and 100 mils. And we need to gradually increase that capacity over time. To start off with, you may leak quite a lot, particularly when you cough and standing. And we would have taught you pelvic floor exercises before your operation, which you can start redoing afterwards to strengthen these muscles. We increase the volume of the neobladder by extending the time between you passing urine. I usually start with going every hour with 2 hours at night and gradually increasing the time interval as you're able to hold the urine longer, which will stretch the size of your neobladder. Unfortunately, some patients don't empty their neobladders well, so they need to do self-catheterization. All patients will need to do this initially after their operation, but the majority will be able to stop using the catheter long term once they're able to hold more urine and become better at emptying the neobladder. Because a neobladder is a piece of bowel, it doesn't have the muscle of your native bladder, so you will learn to use your abdominal muscles and bear down to squash the neobladder from the outside to help it empty. Most people gain their continence during the day, but at night time, particularly if you're in a deep sleep, most patients will leak a little and will need to wear a pad at night. You should get ongoing support from your bladder or cystectomy nurse and also your stoma nurse if you have a stoma. Your urology team will keep a close eye on you with the follow-up, and following the histology coming back from the lab, you may need to have further oncology treatment, for example, further chemotherapy or immunotherapy, and the oncology team will manage that in conjunction with the urology team. There are lots of charities that are very helpful and support groups, including Fight Bladder Cancer, which patients find really valuable. There's also the Urostomy Association, which is very good for the patients with stomas.
Thank you, Alison. Mark was diagnosed with grade 3, stage 2 muscle-invasive transitional cell bladder cancer. He opted to undergo a robotically assisted surgery to remove his bladder. Following the surgery and recovery, Mark initially planned to retire, but eventually decided to open another business. Mark has also made a conscious effort to step back and enjoy his leisure time. He is married to Tatiana and has 2 grown-up children. Mark, the floor is yours.
Hi, my name is Mark Christie. I'm 64 years old. I was diagnosed with bladder cancer, grade 3 and T2 in 1999. I had an operation in January 2015. The options were left to me were chemotherapy, have my bladder taken out. And after all the investigations and advice from professionals, I decided to have an operation with robotic surgery. I was fortunate enough to be having private medical insurance, and my questions to the doctor on arrival and my first interview with the robotic surgeon was to ask him three things. Could he save my life? Could he save my sex life? And get on with it. Once I got the answers to the first two, which were all positive. The reason I chose it, as I've said, it's precision operating. It meant that the nerve endings were carefully guided by a machine with a surgeon on the back end of it, looking at a massive big screen. My operation took 13 hours, and there were no real problems. 5 days, very painful 5 days, I will admit. However, I was in CPI for at least 2 days, and I was well looked after. Frightened I was, and of course, everybody will be frightened. However, there is a lot of positives. I have, since I had that operation, the first 3 months I was at home recuperating and recovering. And it's true, you can't do too much. You must take it easy and look after yourself. Staying fit and more so positive is the answer. After 3 months, I was walking around and I decided to go back to work with a friend of mine, and I set up a business there. In the period from having the operation to the business, it was about 6 to 7 months. And it took a long time for me to get my head around things and to sort out exactly how I was to wear a bag, because I had an external bag put on, and how I dealt with it on a daily basis, and more so a nightly basis. I don't know if you're aware, but if you have an external bag, at night time you connect to another bag which sits on the right hand side of you, or wherever your bag on the left hand side. However, it is difficult to do for the first couple of weeks, but you soon get used to it. And there are some very great positives. And certainly at my age now, you gentlemen who have not had this experience, but do tend to have problems with your bladder, end up going to get up in the middle of the night to go to the toilet 2 or 3 times. I don't. It all collects in a separate bag, and all it simply needs to be emptied in the morning and cleaned out hygienically and changed every 2 days. That's my position. There are, of course, other benefits. If you don't have a few beers, you don't end up running to the toilet every 5 minutes in the public house. And that probably is not a bad thing in anybody's case. The negative side of life, well, yeah, you do have accidents. Do you have an understanding wife or partner or yourself? And just make sure you have plenty of bed sheets and undergarments to make sure it doesn't stay in your mattress. And you have it in your day frame, in your everyday working environment. I, for example, put on some weight in this time because I couldn't do full exercises. And I ended up by being from a 36 to a 40. And I started wearing braces to ease the pressure on where the seam of the trousers, the waist of the trousers hit the bag, so it wouldn't burst. Haven't got over that. I did start losing weight in the second year, started walking a lot more, cycling, and eventually was determined to lose enough weight so I could go skiing. So now, as I say, I'm skiing. It's been nearly 8 to 9 years since I had this. Yes, initially it was daunting. Yes, it was frightening. But once you got on the mend, the support behind you is fantastic. More so with the checking of you on a general basis. Every 6 months I was checked. Unfortunately for me, and unfortunate for me, those scans every 6 months and every year, I've spotted a small nodule in my lung 3 years ago, and it was below 4 millimeters. It's an isolated nodule. So I'm having radiography only in a couple of days' time, 5 sessions, and that will be that cured. It's curative, so therefore I'm a very lucky person because they spotted it. Again, I will be checked for the rest of my life, and you don't get any better than that. And that's actually with the NHS, which seems to have a very quick turnaround in my experience with cancer patients. As far as everyday living goes, you forget you've even got a bag. You forget about it. You'll never forget the operation. You'll never forget the day it was on. You'll never forget it at all. And here I am, 9 years later, positive, still working, granted, taking a bit of a back step, but enjoying life to the full. So, guys, just stay positive, get your advice, and then make whatever decision you think is necessary for yourself. Nobody can give you that decision. from me, I wish you all the best, whatever decision you make in the future. And all I can say is be positive all the way through it. Thank you very much.
Thank you, Mark. Anne was diagnosed with bladder cancer after many delays due to COVID. After a TURBT, she discovered she had muscle-invasive bladder cancer, G3PT2 transitional cell carcinoma. After 3 cycles of cisplatin and gemcitabine in vitro chemotherapy, she chose to have a radical cystectomy. She enjoys walking her dog, swimming, gardening, and is now a community governor of her local primary school. Anne, the floor is yours.
Hello, my name is Anne Wass, and I was diagnosed with muscle-invasive bladder cancer when I was 58 years old. I opted to have an ileal conduit, more commonly known as a stoma, and therefore live with a bag stuck to my tummy to collect my urine. Sound awful? It isn't. Prior to having my radical cystectomy, I was offered an alternative of further chemotherapy combined with radiotherapy. As a patient, it can be difficult to come to a decision regarding which route to take, as you are trying to make a very big decision whilst being emotional and vulnerable. For me, it was relatively easy to decide, as I didn't want to try and hold on to my bladder that was effectively trying to destroy me. My advice, if you are faced with this decision and feel undecided, would be to seek reputable information from the Fight Bladder Cancer website and Macmillan, and also to contact either of these organisations to see if you can talk it through with someone who themselves has had to make this decision. Looking back, my experience and recovery of having robotic surgery went pretty smoothly, really. The morning of my surgery, I really did feel sick to the bottom of my stomach with fear and anticipation of what I was about to undergo. My legs were like jelly, but actually once I walked through those hospital doors, it was amazing at how much strength I can find within myself at such a critical time. I was in theatre for just under 6 hours, and as well as having my bladder removed, I had a full hysterectomy and 41 lymph nodes were taken away for analysis. It is big surgery though, and it takes months of a patient and slow recovery. Before my op, my cancer nurse specialist said to me, "Treat your recovery like it's a marathon, not a sprint," and how right she was. I spent 2 days on a high dependency unit before being transferred to a surgical ward for another 7 days. The pain post-surgery was nowhere near as sharp as stabbing as I had imagined, but I hadn't actually anticipated how sore and uncomfortable I would be every time I tried to move or lie down. Trying to get comfortable in the early days was tricky. I felt like someone had done the washing up inside my abdomen. Definitely a feeling of someone having a good rummage around inside me. Keep moving post-surgery and this will help your recovery. I can remember just walking around my bed to get to the day chair was simply enough at first, and then I ventured a little further to the entrance of the ward. I wouldn't actually call it a walk as such, it was more of a very slow shuffle. But by the time I was discharged 9 days later, I was able to walk to the end of the ward, but it was a big effort. Roll the clock forward, and 7 weeks post-op, I was able to walk 2 miles, and once again, having the surgery robotically definitely jump-started my recovery to fitness. I met my surgeon before the operation, and everything was explained to me, but I think the fear in my body stopped me from taking it in all the information, and so I would definitely recommend taking somebody with you, and also take a notepad and pen to this appointment to write as much down as you can. I didn't actually ask that many questions, and I just think that was my way of not being overloaded and overwhelmed with information that I knew would worry me. Typically though, after that appointment, there were a few things that occurred to me that I wish I'd asked, but I knew I had my wonderful cancer nurse specialist team who always helped and supported me and made sense of all the technical jargon that you hear at appointments. She always put things into simple terms for me, and I really don't know what I would have done without her. She was always just a phone call away and provided me with great comfort and support. I actually didn't find the Fight Bladder Cancer Facebook support group until 2 months post my surgery. and how I wish I'd found them before this, as it would definitely have prepared me better for what I was going to face both pre and post surgery. There is nobody better placed to understand all your fears and worries than people who've gone through a similar experience. To sum up, what can't I do now that I could before my robotic surgery? The simple answer to that is I can do anything I want to do.
Thank you, Anne. We now open up the floor to your questions. Please use the question and answer box on your screen to ask questions to the speakers. A neobladder instead of a bag. Can one ever go more than about 4 hours before having to empty? Matthew and Alison, can you answer that?
You can, but we try to leave it at 4 hours because we don't want to over stretch the neobladder. The longer you leave it, the larger the capacity, and the neobladder can become too big. So we try and save 4 hours, really.
Thank you, Alison. The next question we have is from a patient who says, I'm still leaking fluid from the site where my bladder was 3 weeks post-operation. How long should this happen for, please?
So that certainly can happen. It's usually from the removal of the lymph glands, and the fluid that goes through those lymph glands continues to be produced. So 3 to 4 weeks is our average here in Guildford. The longest we've had is 6.5 weeks. And it seems that smokers might have a slightly longer leak than others, but it will stop. So don't worry about it. It will stop. But yeah, it can take a variable period of time. But 3 weeks is actually about normal.
Thank you. The next question I'll pass to Anne and then to Alison. Any advice, please, on how to position the night bag to the urostomy bag to make sure it drains properly, as my urostomy bag is filling, but they're not draining into the night bag. So Anne and then Alison.
Okay, well, I always make sure there's a small amount of wee left in the normal day bag before connecting my night bag. And I also always make sure that the flow is going through into the night bag before I actually settle down and I'm horizontal on the bed. I also use a catheter leg strap on the top of my thigh so that the tube from the night bag connecting to the day bag doesn't get all twisted, and I find that works for me.
I would agree. That's the advice that I give everybody. So it's just making sure there's not an airlock and priming the line first with the urine.
Thank you. The next question is to Matthew and Alison. As the incisions are shorter than with open surgery, is the risk of hernias as great? And two, might it be easier to overdo things with smaller cuts?
The risk of hernias, in fact, the risk of all wound complications is slightly less with keyhole surgery. And no matter what surgery people are going to have these days, keyhole surgery is becoming more and more prevalent because of exactly this sort of problem, becoming less of an issue. So the second point is if you're lulled into some sort of false sense of security, I guess, with smaller things, well, we would discourage you from overdoing it too soon, and we do give people a kind of program of activities that they should be aiming for, but not trying to do too much, if you see what I mean. So we do try and temper your enthusiasm, slow down and make sure you're taking the time. And I think Anne summed it up very well with, this is a marathon, it's not a sprint. And that is a message that I think everybody in their recovery needs to take home.
And do you have any more comments on recovery and advice for taking things slowly?
No, I agree with everything. And I am very conscious of what I lift. Even now, 2.5 years post my RC, I still am incredibly careful about what I lift. I use a support wrap belt around my tummy if I'm doing anything like gardening or hooving, anything sort of that takes a bit more effort, just to protect myself, really. And just be sensible.
Thank you, Anne. There's another question. Will this be recorded and available? Yes, it will be. So the next question is for Matthew. If we look at the differences between open surgery and robotic surgery, and we look at pain during recovery, can you comment on the differences in pain during recovery between open and robotic cystectomy?
One of the outcomes from the trials that have been done is to look at this as well as a sort of sidearm of those trials, and they do show that usage of heavy painkillers is less with keyhole surgery. So that is one of the drivers of us moving more towards that. Less heavy duty painkillers means that the bowels get better quicker. So anything that we can do to decrease pain means that we decrease painkillers, which means you get better quicker. So if it is available in your area, then I would go for a robotic assisted keyhole approach.
Alison, can you comment on pain after surgery?
Certainly from my experience, patients do better with the robotic from a pain point of view. I think they get more, with the trap wind tends to be more painful than the operation sites generally compared to an open procedure. So it's definitely less, and a lot more they can do by walking around and everything else that can relieve that, in addition to obviously the painkillers.
Thank you, Alison. And two questions for you. One, if you could comment on pain after surgery, and two, if you could talk about how to get the support belts, please. And Alison, perhaps you can also talk about how to get the support belts. So Anne, pain and support belts.
Okay, pain after the surgery was really not as bad as I expected. It wasn't anywhere near as severe. I did feel very bruised. I think that's what I wasn't expecting. But it was very manageable. I had a self-administered morphine pump for the first day or so, but quickly didn't need that. It was more just being uncomfortable. It wasn't incredibly painful, but it was just that sort of bruising and stiffness from where you're put in a funny position on the operating table, that the muscles all didn't feel right. If that makes sense. So that for me was the most uncomfortable, and it took me a long time to be able to lie down in the evening to go to sleep before I felt really comfortable. But I think that's to be expected after that sort of surgery. And the support belts, it's like a big oven glove that goes around your tummy, and it's Velcro, and you can stretch it so you can make it feel really nice and tight to your body. My stoma nurse gave me a contact of a company, and the lady came out to my home. So I can't remember off the top of my head who it was from, and I should know, but it's available on prescription as well for the first one, so it doesn't cost anything, because they are quite costly to purchase additional ones afterwards. But I would contact the stoma nurse, and someone should be able to come round, and I had someone come to measure me as well.
Yeah, I would agree. Stoma nurse would be the first port of call, and there are different levels of support. So some people wear just a light one that just maybe smooth things off under their clothing. Quite a few of my ladies just wear support underwear. So just, rather than support belts, just some tight fitting pants. And then obviously the stronger ones for more, gardening or hobbies like that. So there's a lot of people have different levels of support wear, but the stoma nurse would be your first port of call to be able to advise on how to get that on prescription.
Thank you, Alison. A question for you, Matthew. Why do some urostomy stomas protrude more than others?
That can be due to a number of things. It can be due to the length of bowel that we choose, but actually, more importantly, it can be the blood supply to that length of bowel. Sometimes they don't stretch as much as we would like. Sometimes it's the patient's body habitus, and we all have different fat layers within our bodies and on the outside of our bodies. And the fat layer between the muscle layers as well. So there can be multiple reasons why some will protrude and some won't. And in fact, they can change over time. So some will protrude and then retract. Some will be flat and then protrude. So they can do all manner of different things.
Thank you, Matthew. A question for you, Alison. I still catheterize 3 times daily. Is this unusual?
No, I've got a real mix of people. Some catheterize more than others, so it just depends on the person and how compliant their near bladder is. Some people, by do more exercises to strengthen the muscles, can improve bladder emptying, but some people do just need to catheterize. It's just one of those things that you won't necessarily know beforehand. And I've also got some patients that will actually catheterize for convenience, because if they're slow at emptying, they'll sometimes continue to make it easier for them.
Thank you, Alison. Another question for you from a patient. What happens if you can't give up smoking before surgery? I've cut down drastically and I'm trying my best to quit, but it's such a stressful time.
I mean, all you can do is your best. I think that was the way to say, and everybody's good intentions, but you can only do your best, and it's something that you can look at later on if you're not able to. Some people maybe go on to vaping just in the short term beforehand. Some patients nicotine replacement if it's that helps, but you can only do your best.
Thank you, Alison. A question for Anne. We've got a nurse that says, wow, what an amazing story. Congratulations on your recovery. I'm a urology nurse in Guernsey, and we usually send our patients away for radical cystectomies, so we rarely get involved with their pre-operative support. What additional support would have been valuable for you when preparing for your surgery?
Well, I'm now part of a group close to it's about an hour's drive from my home now, but I didn't find that group until after I'd gone through all my diagnosis and treatment and then my surgery. So I think that would have been really valuable to have been able to tap into that. And I also didn't, as I said, I didn't find the Fight Bladder Cancer forum, the Facebook forum, until after my surgery, but it's still a really valuable place to learn and talk to other people.
Thank you. And a question for you, Matthew. What is the lifespan of a neobladder?
The neobladder is you, so it's as long as your lifespan.
Thank you.
So
well, that's...
it's just part of you. So it's not anything false or new or fabricated. It's your bowels, it's your guts, it's you. So it's as long as you live.
Thank you. So we'll do one final question to both Matthew and Alison. How does the trapped gas dissipate after the operation? And then Anne, will go to you for your final thoughts. So last question for Matthew and Alison. How does the trapped gas dissipate after the operation?
So it usually goes on its own. So there's 2 things about the trapped gas. One is it the trapped gas under the diaphragm, which can irritate your shoulders. That usually goes within 48 to 36 hours. The bowel gas, and it's the gripes that you get in your bowels that can be really quite nasty afterwards. Those can take days into weeks occasionally for them to really go, and that's really when you're back on your diet, back in your house, that your bowel habit will settle down, and that's when the gripes will really start to ease up. But they can take some time in some people.
Thank you. Alison, do you want to add anything to that?
No, I'd agree with that. It can take a while for it to settle, particularly the bowels.
Thank you. And Anne, to all the patients pre-operation and post-operation, do you have any words for them?
Just to say it's big surgery, but don't despair, because no matter how bad you feel after the surgery, you will definitely get to a much better place. I never thought I would go out the house again, but I did, and I've gone abroad and I've swum in the sea, and life is good.
Thank you. This concludes our live question and answer session. If you have any questions at all, you can always contact us at info@fightbladdercancer.co.uk. I want to take a moment to talk about Fight Bladder Cancer and the valuable resources we offer to support individuals and their families on their bladder cancer journey. Our website serves as a hub of information, offering a wealth of resources at your fingertips, from educational materials to personal storage of courage and resilience. Our website is accessible wherever you need it, ensuring you can find guidance and understanding whenever you need. We also produce a free monthly newsletter that keeps you updated on the latest developments in bladder cancer research, treatment options, and community events. We also publish a regular Fight magazine. This publication dives deeper into various aspects of bladder cancer, featuring insightful articles, interviews with experts, and inspiring stories of individuals who have triumphed over their disease. It's a valuable resource that aims to empower and educate our community. Furthermore, we understand the importance of having a supportive community to lean on during such challenging times. That's why we offer a moderated private online forum that provides a safe space for individuals to connect, share their experiences, and seek advice. It's a place where you can find comfort and understanding from others who truly comprehend the journey that you're on. To facilitate further connections and support, we also host regular online Zoom support groups. These virtual gatherings allow you to interact with others facing similar challenges, providing an opportunity to share, learn, and find solace in the company of people who truly understand. Lastly, our Bladder Buddy system offers a unique way to connect with someone who shares a similar diagnosis. This one-on-one support system pairs you with a fellow bladder cancer person, creating a bond that can provide encouragement, guidance, and a sense of companionship throughout your journey. Thank you for being part of our community, and please know we're here for you day or night. I want to highlight the invaluable patient information booklets that we produce. These booklets provide vital resources for individuals navigating life after bladder cancer surgery, specifically focusing on two essential topics: living with a neobladder and living with a stoma. The Living with a Neobladder booklet is a comprehensive guide designed to support people who have undergone neobladder reconstruction surgery. It offers practical advice, insights, and strategies to help you adapt to life with a neobladder. Additionally, the Living with a Stoma booklet is a crucial resource for people who have had a stoma created as part of their bladder cancer treatment. It provides essential information on stoma care, managing the day-to-day challenges, and maintaining a healthy and fulfilling lifestyle. This booklet addresses common concerns, offers practical tips, and highlights the support available to ensure you feel confident and empowered in living with a stoma. These resources have been developed in collaboration with healthcare and professionals and individuals with lived experience, ensuring that they address the most relevant and pressing concerns faced by those living with a neobladder or a stoma. We provide all of our support and information materials free of charge. Fight Bladder Cancer relies on the support of compassionate individuals like you to fund our initiatives and support programs. Every donation, no matter the size, helps us provide essential resources, raise awareness, and advocate for better bladder cancer care. Simply visit our website at fightbladdercancer.co.uk/make-a-donation, where you can securely make a donation online. Alternatively, you can call us directly on 018 44 352 621 to make a donation over the phone. For your convenience, we've also displayed a QR code on the screen. By scanning this code with your smartphone, you'll be directed to our donation page, where you can easily contribute to our cause. We appreciate every contribution, as it brings us one step closer to our shared goal of improving the lives of those affected by bladder cancer. If you have any questions at all about anything that you've heard today, please don't hesitate to contact us on info@fightbladdercancer.co.uk. You can also find more information on our website at fightbladdercancer.co.uk. We also encourage you to reach out and join us on our social media platforms on Twitter, Facebook, Instagram, and LinkedIn. Once again, we appreciate your presence here today, and thank you for joining us.